Thank you so much for joining us today for the webinar MI Restoration of the Deeply Cavitated Caries Lesion. It is a great pleasure to introduce to you Dr. Avi Banerjee, whose aim during this presentation will be to discuss about adhesive materials, minimally invasive clinical and operative techniques. Since qualifying with BDS from Guy's Dental School, London, UK, UMDS in 1993, Avijit currently holds a chair in cariology and operative. He is an internationally renowned lecturer and primary author of Picard's Guide to Minimally Invasive Operative Dentistry, Oxford University Press, 10 edition 2015, a definitive and globally respected text in its field. He is now editor-in-chief of Oral Health and Preventive Dentistry and is an active editorial board member of Dental Update, British Dental Journal, Primary Dental Journal and International Journal of Adhesion and Adhesives, serves on the British Dental Association's Health and Science Committee, helping to guide the association's stance on professional policy. We would like to thank Dr. Banerjee for being with us today and GC for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. Banerjee at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Avi Banerjee.
Great, thank you, and thank you everybody for logging in this afternoon. It's 5 o'clock in London, and hopefully you can see my opening screen, and the building I'm circling with my mouse is actually Guy's Tower, part of the hospital there, and I'm sitting in the middle floor somewhere here talking to you all around the world. So thank you very much for giving up your time to listen. So why are we here this evening? I hope in the next sort of 40-45 minutes I can give you an overview on the management of the deep carious lesion. We're really here to look after our patients and help prevent and manage this sort of condition. And I think the key word on the screen is actually the word help, because no dentist or member of the oral healthcare team can actually prevent this condition from occurring. The only person who can do that is the patient who owns the mouth. You'll also see on the slide, and a few others during the presentation, a link and a QR code to find out more information about my master's program in advanced minimum intervention dentistry, where we teach dentists and members of the team how to actually look after our patients in this new modern MI rationale. And indeed, the method used to manage deep lesions is moving away from the traditional based cariology and caries removal regimes, which I'll talk about a bit later. And we're now using MI. And I think it's very important that people understand what the terminology means, because this is a term that's used by a lot of people, but sometimes erroneously. So here we can see on the screen the first main definition of MI, that is minimum intervention care. And as you can read, this is a patient-focused approach where the oral healthcare team gives advice and treatment to prevent disease in the mouth and to maintain lifelong oral health. The second and perhaps more popular definition of MI is minimally invasive dentistry. This is actually part of minimum intervention care, as you will see shortly. And here we're really talking about new approaches to actually operatively managing the carious lesion. We're taking active lesions, and rather than cutting away all the diseased tissue, as in the traditional approach, we are now advocating more selective carious tissue removal and sealing in tissues with good quality adhesive restorations. So really, as I've said, the surgical, excisional, mechanistic approach to caries removal is now not appropriate. So the primary aims of MI dentistry, when we're talking about the patient sitting in the clinical chair, risk assessment is a critical part of managing a patient with MI. It's vital that the team, headed up by the lead dentist, can gain all the critical information from the patient and from the examination to be able to risk assess the patient's disease susceptibility And this applies to caries, periodontal disease, mucosal disease, etc. This risk assessment will allow us to empower our patients to make responsible lifestyle choices. Again, this is critical as the main diseases that affect the oral cavity, periodontal disease, caries, tooth wear, etc., even though I accept tooth wear isn't a disease as such, these are lifestyle related conditions. They're behavior related. And the patient can manage these conditions if they can manage their lifestyle choices. And it's our job to help them do this. And we do this using pragmatic care regimes. And pragmatic, what I mean by that, are not necessarily textbook care regimes, but ones that will fit for the patient sitting in front of the clinical team. And it's a two-way interactive process. When I was working out how to try to explain MI dentistry, I felt that it was cogs turning in my head. And I think if you understand MI dentistry as 4 cogs turning in your head, then it's easier to explain this to your patients. It's very, very obvious, and you can see there, it all revolves around team care, delivery, and it's patient focused. And the first critical cog is the identify part of the whole process. We have to identify what's wrong with the patient, as I've already mentioned, risk assess it, and then care plan it appropriately. And you'll notice there I've written DCP in white, and that's dental care professional. These are other members of the team that can be used in these processes. Once we've identified the problem for the patient, we then need to prevent or control it. Here, the oral health educator nurse, the DCP, reception staff, and others can all be involved in this management. And it's a very critical one that will continuously underpin the whole of the care that we offer. We are still dental surgeons, however, and our patients will present with lesions in the mouth that require operative intervention. This is where minimally invasive dentist comes in. And in the UK and other countries around the world, we also have dental therapists who are permitted to do these procedures on patients, either independently or with a dentist looking over them. Tying in with all of this, we need to recall our patients. And this is an important part of terminology because certainly in the United Kingdom, this appointment is often called a checkup appointment. And this is a bit of a throwaway statement, which most patients will not understand and thus imply that this appointment is not very important. It is actually a critically important appointment, and the recall consultation will allow us to review and reassess the actual treatments we have done, as well as reviewing and reassessing patients' behavior and their adherence to the advice that they've been given. And from this, we can then tailor their appointments and their treatment strategies for the future. Now, in this very short webinar, I don't have time to discuss all these cogs, all these sections in massive detail. So what I'm going to do is concentrate on the restore cog, the minimally invasive aspect of deep caries management. But please do understand the other aspects of MI dentistry are just as, if not more important than this section. So one slide summing up non-cavitated carious lesions. We can see the radiograph with early lesions into enamel, and also the picture here showing the inverted cone of the white spot lesion, and it's an arrested lesion in this particular case. And these lesions must be managed always by first assessing the patient's caries risk and then non-operative prevention and control methods, as I've listed on the screen. If these are not working, then consideration may be given to operative intervention, but one must understand that without the patient's cooperation and their effective use of a toothbrush, all operative intervention will ultimately fail. So if we now talk about the cavitated deeper lesion, we need to understand how the philosophy has now changed, moving away from the traditional approach we can see on the left, sort of the GB Black's approach to cutting specific shapes in teeth. And this has been dictated to by the types of material we've used in the past, i.e. dental amalgam. If I mention to you a class 2, you can immediately picture a three-dimensional shape in a tooth. This is a very mechanistic approach, sort of carpentry approach to operative dentistry, and is no longer indicated. We need to understand the caries process, the bacteria, the biofilm, and also the adhesion technology of our modern materials, which allow us to seal in residual tissues and allow the dentine pulp complex to actually repair itself biologically over time. Again, it needs the patient's cooperation with oral hygiene to maintain the optimal environment in the oral cavity for this to occur. If we're looking at optimal adhesive restorations, there are 3 key aspects to this that one must be able to handle and understand to make adhesive restorations work. The first is looking at histopathology, looking at the histology of the tissues, understanding what's actually occurring in the structure of enamel and dentine, the collagen, the tubules, the mineral, the bacteria, and the disease process itself. We also need to appreciate properly the chemistry of the adhesive materials we're using, bonding agents, the adhesive materials, and we'll talk a little bit about this as we go through the presentation. The third cornerstone is clinical handling. Clinicians are usually pretty good at this aspect, managing the patient, the oral cavity, moisture control, the instrumentation, etc. And if you put all these points together, you can start to place good quality adhesive restorations, which can then be maintained effectively by the patient. So really, in a cavitated lesion like the one I'm showing you on the right-hand side, the yellow dotted outline of the soft, wet, caries infected dentine is the only real tissue that requires excavation. And when we're considering the management of deep caries and the amount of tissue that we should be removing, there are certain factors that should be at the forefront of our minds when making these clinical decisions. I think the most important one is the vitality or sensibility of the pulp. We must take proper histories to appreciate the signs and symptoms of an acute pulpitis or reversible or irreversible pulpitis. If the pulp is still giving symptoms and signs that it may still be vital, then it's worth trying to save the dentine pulp complex. It is a very resilient tissue and it should be given the opportunity to try to heal itself. Linked with that is how deep is the lesion and how close it is to the pulp chamber itself. And often many studies look at the remaining dentine thickness, which is those tissues that underlie the main lesion as it approaches the pulp. The argument being the thinner the remaining dentine thickness, the worse the prognosis of the pulp. Yet I will show you some data shortly that might counteract that argument. Of course, teeth should be restorable. There is no point taking a carious tooth, excavating the tissues, to find that the tooth itself is so badly broken down that it is not restorable. And consideration needs to be given to the adhesion potential of the remaining tissues. Can they be isolated effectively and managed properly to optimize the chemical and physical adhesion we look for? There'll always be operator and clinical factors, differences in the clinical skill and the situations and the technologies that are available, and this always needs to be factored in, as does with the patient, as we've mentioned already, their caries risk. All of these factors together will help you make the right decisions to decide on how to manage your deep caries lesion. So why do we excavate caries? This is an important point that many of us forget to ask when actually carrying out operative procedures. Remember, as good quality ethical clinicians, you must always justify every decision you make. And in terms of why we excavate caries, this is very, very important. Do we need to remove all the caries? Why do we do it? Classically, most of us around the world, depending on how old you are and when you went to dental school, were taught that we excavate caries to try to remove the soft tissue, to get a stronger substrate to support the restoration, and also to remove bacteria to prevent the lesion from progressing towards the pulp. Well, is this really true? I might show you some evidence shortly that will argue that it's not. I think we would all agree that deep lesions should be restored to obtain structural, functional integrity and aesthetics in the oral cavity. But actually the main reason for restoring cavities is so that we can provide a cleansable tooth surface so the patient can remove regularly and effectively the surface biofilm on the tooth. Because it is that, and it's the bacteria in that surface biofilm that actually drives the lesion through the tooth towards the pulp. It is not necessarily the bugs that are within the lesion itself. Now, I'm very fortunate to have worked at King's College London at Guy's Hospital for many years, and indeed I trained here, but I do also work in practice and treat patients on weekends. And in the areas around London where I work, we do unfortunately still see mouths like the ones on the screen. Now, I often lecture in the UK and abroad and show this slide, and it's very interesting because as a clinician, as a clinical dentist, you can see these pictures, and in a very short time, a split second, you can detect the problem, diagnose the problem, you can care plan the patient, and you can execute the treatment in your head. That is a real skill that very few healthcare professionals have. And I would say dentists are right at the top of the pile with this sort of skill set. You can look at that situation and hopefully you won't expose the upper left lateral incisor when removing that caries, and you can restore that. And you know that when you look at a lesion from the surface, that beneath it, you can also find an exquisite histological structure. Here you can see a section through a representative cavitated lesion. The cavity is here. You can see the enamel dentine junction where the pointer is running. You've got the dark brown, soft, wet caries infected dentine that then blends to the affected dentine in the deeper regions. You have the translucent dentine, which is a repair sort of zone, and off the screen at the bottom here you'd have the pulp chamber. And I understand there's several of you logged on this evening, and if this was on your screen and you had a pen and I asked you where you would stop excavating to when preparing this cavity, we would get many, many different lines, which is what makes dentistry exciting. I was taught originally 25 years ago to remove caries until the dentine was yellow and hard. Maybe over the pulp we could leave a bit of stained dentine, but elsewhere everything had to be removed, especially at the enamel dentine junction. Those of you who've kept up with the literature will be aware that perhaps we don't need to excavate so much, and as long as the margins are healthy, and here we can see the lines actually starting and ending on healthy enamel, with a good peripheral seal, this restoration could be sealed. And some might even argue we could go really conservative and remove a very minimal amount of tissue, and in some studies, no dentine has been removed and lesions have been sealed, capped off, a little bit like a cork in a bottle. And as long as the peripheral seal is maintained, there is a good chance that these restorations will last. And this is what the evidence shows us. Now, these ideas aren't new. Stepwise excavation has been in dentistry for 50, 60 years. The idea that you can remove the soft, superficial layer of infected necrotic dentine with a spoon excavator and then place a calcium hydroxide lining and then a provisional adhesive restoration. After a few months, you can go back in, remove that restoration, and you can see the lesion has arrested beneath the surface. And here we have a very elegant series of images that David Ricketts, who's a professor up in Dundee in Scotland, has very kindly let me use. He's a good friend and colleague of mine, showing a case he's treated where we have a large amount of occlusal caries in this tooth, which we can see here with the pointer just showing the radiolucency, and yet the pulp is still vital. Once the lid has been taken off and the caries removed, you can see how plenty of carious dentine is still retained, but there is no pulp exposure. Calcium hydroxide is placed, and then the restoration sealed with glass ionomer, and then within 2 months, been opened up again, and you see the classic hard, dark, flint-like arrested lesion beneath. The argument to say now is if these restorations are sealing so well and the quality of the chemistry is so good, why do we need to go back in for the second visit? Why don't we make that provisional restoration the definitive one? And people have studied this, and Lars Bjorndal and his colleagues published an elegant paper about 5 years ago in the European Journal of Oral Sciences, where they did a real-life trial looking at sort of minimally invasive caries removal versus sort of conventional and complete excavation. You can see that this was done in practice with a large number of authors, and I appreciate there's a lot of small print here. Don't worry about that so much. It's really the take-home message, which was if an exposure was created by the excavation process, the chance of that pulp dying and perishing was massively increased. If carious tissue was retained and a good quality sealed restoration placed, pulps had a much better chance of surviving. So bottom line, the best lining material, in inverted commas, the best pulp protection would be the dentine itself, assuming the pulp is still showing signs of vitality. There are meta-analyses and systematic reviews of this topic, and gradually these are increasing in number and quality. And the most recent Cochrane database systematic review has been updated. The one that's on the screen has now been updated to 2013, with 8 papers included in this review. And we can see there that with this analysis, it is clear that sealing in residual caries affected dentine with good quality restorations and then good quality maintenance of the patient shows that these lesions do not persist, and indeed the dentine pulp complex heals. The restorations survive well, and by reducing the risk of pulp exposure, this in turn reduces the risk of pulp death. It is clear also restorations are retained well. Modern adhesive materials can be reasonably strong in relatively thin section, so the mechanical aspect of placing restorations is something that needs to be considered. It is less of an issue in deep lesions, where there is usually enough bulk of material to support the restoration. One of the sort of seminal papers that's often quoted in this area are Ava Metz-Fairhurst's series of papers that were published a little while now, where over a 10-year prospective trial, they sealed restorations and then reviewed them regularly with good quality oral hygiene and maintenance. And the results showed that the sealed restorations actually survived better, and the teeth survived better than those with extensive traditional excavation. And here we can see an example of one such clinical situation at baseline at 6 years and at 10 years. And a close-up examination of the 10-year restoration will show us that the cork in the bottle, the lid on top of the lesion, is now possibly perishing. The quality of that composite restoration now is probably not good, may well be leaking. So the treatment would be just to remove that superficial cork and replace it with a modern resin composite restoration. Simple operative dentistry. So when we see an exquisite histological structure of a cavitated proximal lesion such as this, where we can see the cavity, the enamel dentine junction, the different shades of the histology of the caries process down to the translucent dentine, and then the pulp over in the bottom right-hand corner, if we analyze this, we can understand the histological zones of the lesion. You have the caries infected dentine. This is the tissue that desperately needs removal because it's necrotic and it's very difficult to seal and bond to. The remaining tissues, zones 2, 3, and 4, collectively could be called the caries affected zones. And it's this tissue that is actually repairable by the dentine pulp complex. And if possible, it would be ideal to try to retain this in the tooth. This makes restoration smaller, more manageable to place, and therefore easier to maintain by the patient. If we're looking at that in a graphical form, where on this graph we can see the enamel dentine junction going off towards the pulp, and the relative hardness of that tissue, we can see how currently sort of more traditional approaches will take excavation into that affected zone where the dentine is a little bit harder, and perhaps all we need to do is concentrate on the more superficial caries infected aspect. The difficulty is, how do we know that transition between the two? And clinically, that still forms a challenge. And this is where the sharp dental explorer being dragged across the surface of the dentine and feeling the relative stickiness and scratchiness of the tissue may be our only indicator at present, although there is research being done on trying to produce chemical indicators and dyes that will allow us to differentiate between these tissues. So in histological summary, we have to look at the patient factors, as I've mentioned at the beginning. We need to appreciate lesion histology and the chemistry of the materials. And we can see it's the boundaries, it's the peripheral seal of our restorations that really hold the key to a successful management, coupled with patient maintenance. So if we then move quickly on to the potential materials we have available, I want to run through a short series, some historical, some more modern, of the materials that are available to help manage the pulp, really, when we're looking at deep caries, because ultimately that's our prime objective, is to maintain pulp sensibility. I prefer the term pulp protection to linings. I feel linings is a little bit traditional and really unnecessary nowadays with modern adhesives. But calcium hydroxide still has a part to play, especially in direct exposures. I think for indirect pulp capping, I don't think this is really necessary anymore in these deep lesions. I put zinc oxide eugenol restorations there purely for historical reasons. I would not advocate the use of those. But glass ionomers at the base of a deep cavity to try to protect the pulp, especially if you have chosen to place a deep amalgam in the tooth, this may well be a sensible option. There is a strong body of opinion that favors the use of flowable resin composites in the depths of cavities. When this idea was first reported, there was a lot of resistance due to the fact that we know that flowable resin composites can shrink and whether we can get proper conversion of monomer into polymer. Nowadays, with our bulk fill composites, the chemistry is much cleverer, and this is probably providing less of a problem. So flowable composites that actually adapt well to all the sort of irregularities in a deep cavity may well be an option in terms of pulp management. You can bond to caries affected dentine, which I will show you shortly. I will show you this case a little bit later. And we have other materials, the calcium silicate materials, mineralized trioxide aggregate, and now biodentine, a more therapeutic restorative material. And this material is not glass ionomer, and it shouldn't be compared to glass ionomer in the sense that it's a very different chemistry. Calcium silicate hydrates and calcium hydroxide are produced, which gives a very alkaline pH and lots of good remineralizing ions on the tooth surface. I've recently published with a very good PhD student of mine, Ms. Danya Hashem, a paper in the Journal of Dental Research looking at the management of acute pulpitis with deep caries using biodentine or glass ionomer. And here we can see patients who've come in with large lesions, how they presented. We've performed selective caries removal and restored initially at the baseline with biodentine. These were then followed up at 1 month, 6 month, and 12-month intervals where we could re-radiograph and see the sort of open sandwich restoration that was placed with resin composite in the more radio-opaque here, overlying the biodentine beneath. But we also see this zone of radiolucency. And this is a very, very important point. Here's another example within the same trial where we can see the original lesion, and I'm now superimposing the radiograph taken at 1 year after the treatment had been carried out. And again, you can see the composite restoration, and you can see the biodentine beneath. But again, you see the radiolucency. Now, this is very important because clinically, how do we interpret such a radiolucency? That radiolucency may be caused by any of the reasons I've listed on the right-hand side of the screen. Active disease, residual inactive caries that's been sealed in on purpose, could be a leakage defect. It could, if you didn't know this patient and hadn't placed the restoration yourself, it could be a radiolucent sort of lining or pulp protection material. But also, nowadays, we have another factor. It could also be the effect of the material on the tooth structure. And the way biodentine works, with its alkalinity, it can actually, if you like, burn some of the collagen at the tooth surface, and this can actually lead to a slightly more radiolucent banding subjacent to the restoration. We are following these cases up at 2 and 3 years to see how and if these lesions change and these radiolucencies change. But this is critically important medico-legally, because if this patient leaves your practice and goes to another dentist who takes a radiograph and sees this appearance, many traditional dentists would immediately drill into this tooth thinking there was a problem, and that is not necessarily the case. We need to talk about dental adhesives, bonding agents, and there are 4 types, 4 classifications, types 1, 2, 3, and 4. These all depend on whether you're using 37% orthophosphoric acid as an acid etch initially, as in types 1 and 2, or whether you're using self-etching primers, either milder ones in type 3 or stronger ones in type 4. And again, understanding your histology and understanding how the chemistry of these materials work is very important in actually managing patients and carious tissues. Some work we published several years ago now, when we were looking at different adhesives with different composites and bonding systems, and we were actually trying to assess their efficacy to bonding to caries affected dentine. And we had lots of different groups. You can see the reference there at the top in the title. We had lots of different experimental groups with selective caries removal and then bonding to proper caries affected dentine. What I was saying, I'm just moving back to this, is that if we bond to caries affected dentine compared to sound dentine, we're getting bond strengths of around 25 megapascals to caries affected dentine, which is approximately half the natural bond strength of a tooth, which is quite impressive when we're bonding to caries. So again, this concept that we can't stick to caries affected dentine is not true. We can. Here's the example I showed you earlier, bonding to caries. Here's the presentation of the tooth with a large cavity with frosty demineralized enamel, and you can see the lesion here, but the pulp is still vital. We can remove that frosted, undermined enamel, which we can't bond to give us better quality peripheral enamel to seal to. And we can see better the caries infected dentine beneath. This can then be removed with any instrument you wish, large rosehead burr, spoon excavator, and cleaned off fairly crudely to still show plenty of caries at the base of the cavity, but lots of healthy enamel around the periphery. Acid etch is then placed onto the enamel for 20 seconds and then onto the dentine, so you get a bit of differential acid etch, and it's scrubbed in so you can see the bubbles in the acid etch, which is quite important. This is washed off carefully, and we use moist bonding for type 2 etch and rinse adhesive. We can see the tooth has been dried, but not over dried, so there's no frosting of the enamel, and you can see the dentine still looks moist. The type 2 bonding system is then applied, and you can see the subtle change in the sheen of the cavity, and you can see its reflective coating there. This can then be light cured and the restoration built up, in this case with conventional resin composite with an incremental buildup. Tints can be placed here in the Fisher pattern if you wish, and ultimately you convert this tooth to what would be a passable restoration in the patient's mouth, which they can clean and maintain very effectively. You can see the reference from the paper from which these images have been taken from. We also have glass ionomer cements, very, very clever bioactive material that's originally invented in the 1970s. And again, a common misconception is that glass ionomer bonds better to dentine than to enamel. Glass ionomer uses calcium ions to bond, and there are more calcium ions in enamel, so please do remember that that's actually a very useful chemical bond, and a strong chemical bond at that. Here we can see an image with glass ionomer on the left, the enamel on the right, and the GIC has actually shrunk away from the enamel, and you see where the cohesive fracture has occurred within the enamel itself. It has actually pulled the enamel structure apart. That's how strong the chemical bond is to the tooth structure. Hien No is a very good friend of mine, and very kindly lent me this slide, and he teaches on my master's program, which I'll talk about at the end of the presentation. And he did some very elegant work looking at the ionic distribution at the base of a glass ionomer into the tooth structure after minimally invasive caries removal. And when he looked and analyzed at the ions here in the dentine, he found a peak of strontium, which was coming from the glass ionomer itself, about 1/3 of a millimeter away from the base of the glass ionomer here. This shows an element of bioactivity rather than simple diffusion, and glass ionomers are very clever in that respect. Some of GC's own data shows how fluoride can be leached out of some of their materials, including their Fuji Triage and Fuji 9 GP. And this could also be useful in terms of potentially arresting any activity in the depths of the caries lesion. My first paper I ever published as a dental student back in 1993 was a paper that I co-authored with Professor Tim Watson, where at this stage we started to look at surface protection of glass ionomers. In those days, clinicians used to put Vaseline over GIC or even copal varnish. I'm sure some of you might remember those halcyon days with the nice aromas of the varnish in the surgery. I started looking at the use of dentine bonding agents to coat the surface of a newly placed GIC to try to regulate the moisture control through that restoration, as these bonding systems acted a little bit like semi-permeable membranes. And it's interesting how GC especially took this technology on board to develop resin coatings for their glass ionomers. Here we see another example from that same clinical trial I showed you earlier, but this time the tooth was restored with glass ionomer and then veneered with composite and reviewed after a year. And again, many of the teeth and the pulp survived. You can see the glass ionomer here with the sort of closed sandwich of resin composite over the top. GC have now produced Equia Forte fill, which is their latest glass ionomer, and they claim could be used more on posterior restorations due to the new chemistry it contains with fluoroaluminosilicate glasses and these highly reactive sort of filler particles which are made of the same material. You've got a higher molecular weight polyacrylic acid, which increases the binding and increases the setting strength of the material. You must use it with their resin coating, Forte Coat, and this in combination can reduce the wear resistance and increase the acid resistance of these restorations. Some work that has been done by one of my PhD students currently has shown how Equia Forte, the new material, has got a high compressive strength even after a little bit of aging. And we can see here some work done by one of my excellent master's students currently on the AMID program, Avi Banerjee, who shows a restoration being replaced and then restored carefully using the Equia Forte, and then the resin coating at the end, which improves its wear resistance. He will be able to monitor these restorations well as part of his master's program and beyond. And this is a very interesting development because, you know, using glass ionomers on posterior load-bearing restorations, even though has been sort of poo-pooed over many years, now it's interesting with developments in the strength of these materials and the ease of placement, there may be scope to have these easily as provisional restorations, if not as fully definitive. Coming to the end of the presentation now, we also need to look at how we manage long-term maintenance. This is something I said about the whole of advanced minimum intervention dentistry. It's all about long-term maintenance. And one must never just treat fillings and restorations. There is a bit of an obsession in our profession of worrying about how long our fillings will last, when really we should be contemplating how long the filling and the tooth itself lasts, i.e. the tooth restoration complex. The only way tooth restoration complex can fail are listed up on the left-hand side of the screen. Caries associated with restorations and sealants, what was known as secondary caries, pain, plaque stagnation, aesthetics, and fracture and bulk loss. Those are the reasons we would operatively intervene when trying to maintain the tooth restoration complex. And the way to do it now is using the 5 R's concept. Again, not a new concept, it's been published before, but we've sort of refreshed it more recently, where you can review, refurbish, reseal, repair, and replace. So what do I mean by that? Reviewing restorations means taking good quality clinical photographs. And by looking at these serially, you can see how restorations will change over time, but do not necessarily need any operative intervention in their management. You can refurbish surfaces of restorations. There you can see on the top image a rather poor quality surface of a resin composite, which after a little bit of finishing and polishing actually comes up looking absolutely fine. If margins are defective, then they can be resealed, just selectively repairing these restoration tooth margins. Whether it's an adhesive material or amalgam, the same principle can apply. Using magnification loupes is very helpful in this regard. Of course, tooth restoration complex will fracture and can be repaired using all different materials, both amalgam and adhesive, and indeed there will be situations where restorations will have to be replaced. And we can see references at the bottom of the screen there, a paper I published in Dental Update recently, and also the final chapter in the new Pickard's Guide textbook covers these points with the clinical tips written out in full. So the key point is, when looking at caries management, do we remove all the bacteria when we excavate caries? Well, we don't. There's plenty of bacteria that are retained, and as long as the restoration is sealed, these bugs aren't a concern. The bacteria can be affected by the restorative process, that is using acid etch, chemomechanical agents, etc., adhesive resins to actually entomb these bacteria. And as I've shown you, we can actually bond and adhere to this sort of material. So all we really need are restorations that will seal and hopefully chemically heal by helping the dentine pulp complex. So how do we put this into practice? How do we put MI into practice? This is always a real issue because the theory behind it makes complete sense, but actual practical implementation in the UK and other countries can be very difficult. What's taught in dental schools needs to change, and I know for a fact in the UK the teaching is much more towards minimal intervention and minimally invasive, moving away from the traditional towards the modern. We all work in different healthcare regulatory systems around the world who pay differently, and this can be a real problem to clinicians and the oral healthcare teams to try to implement MI dentistry. And this is something that we need to battle as a profession to try to get the healthcare regulators to change the way they look after the patients and look after the profession. The traditional dental practice business model also needs to change. People will argue you can't practice prevention on a traditional National Health Service model in the UK, for example. This isn't completely true, but perhaps if the dentist and the team change the business model, then this could become more appealing. We need to convince the public. At the moment, the public often like to pass the buck towards the profession, and it's the profession's responsibility to treat and cure the patient. It's important to appreciate the only cure for caries is the patient using a toothbrush. Anything we do is just an adjunct. And if the patient doesn't fulfill their duties, anything we do will always end up failing. There isn't a huge amount of practice-based research. And again, this is something we're trying to change with the master's program, where we can actually start to develop proper, good quality practice-based research to start looking at how MI dentistry can be beneficial to the business as well as ethically and morally and clinically for the patient. So in summary, the justification tree for caries management. We've got to look at the patient as a whole and the risk, and look at non-operative prevention and control first. We then focus in on the tooth, the signs, the symptoms, the anatomy, the pulp status, and then decide the level of activity, which I really haven't touched upon today because of time, and the level of cavitation. Classically, if a lesion radiographically is into the middle third of dentine, it is very likely to be cavitated. Therefore, operative intervention would probably be encouraged. And then to decide how much tissue you're actually going to remove. It adapts. In the same large cavity, there'll be areas where you can remove more tissue or less. And this is an important point. So we understand biologically, chemically, and operatively how we want to manage the lesion. We need to take patients along the decision-making journey. This is absolutely critical nowadays. We need to report on our special investigations, our radiographs. Without doing this, the risk of litigation is incredibly high. And remember, if you are the patient, you would want the dentist and the team to do these things. We need to justify our decisions, such a critical word. We have to justify them to 3 people. We need to justify them to the person sitting in the dental chair. We need to justify them to the person who's staring you back in the mirror. And we need to justify them legally to the judge. And if you justify them to the first 2, you don't need to worry about the last one. We need to write very good quality contemporaneous notes. And I feel that consented clinical photography will become part of note-taking in the not too distant future. So always communicate and document, so critical. Why practice advanced minimum intervention dentistry? We can see the reasons coming up on the screen. The evidence is building. There are interactions between the patient and the oral healthcare team, and we can motivate patients more easily. We can integrate the team, and we can clarify patients' responsibility, because it is a 2-way process, and this is so important. We need to think about medical legal aspects, because this too is critical. So the ultimate benefits of the whole principle of AMID is there is this paradigm shift. On my master's program, we will teach you how to use the latest cutting-edge diagnostic, preventive, and surgical skills. We'll teach you how to develop your practice business model, financial models, the use of the healthcare team, the use of social media in all of this, and to develop sustainable and profitable business and workforce models. Because ultimately, it's all about enjoying the work you do. We need to have a good work-life balance and look after our patients and enjoy coming to work. So with that, I would like to thank you very much for listening. If you're interested in the program, please do follow the instructions on the screen there. You can Google KCL AMID, you can scan the QR code, and you can see the main textbook at the top on the right there that I've written that really explains all of this in a lot more detail. Thank you very much for your attention. So I now have a few minutes, I think. We've got about 5 or 6 minutes left, and I have some questions here, I think, which I will go through. I'll read out and then see if we can answer them. There's some very good questions here. There's a question from Irina Senova. I hope I pronounced your name correctly. If the patient comes in with a radiograph with a translucent line beneath the restoration, like I've been showing, how can we be sure whether this is an effect or it's caries? That's a really very important point. And I think what one has to do to answer that question would be to look at all the clinical aspects and the clinical examination. If you were a patient and you went to see a surgeon and the surgeon just used one X-ray to decide whether you needed an operation, you wouldn't be very happy. You would take all the other information into consideration, the history, the signs, the symptoms, the examination, looking at the restoration. If all those factors told you the restoration and the tooth and the pulp were sound, then I would err on the side of caution in terms of operatively intervening. You would take your radiograph, you would document what you have seen and write a radiographic report. You would explain and even show the patient, but I would resist in picking up the drill and cutting the tooth. In another situation where there may be frank cavitated lesions in the mouth and some radiolucencies under other restorations, I would treat the cavitated lesions first to assess how much caries was actually present. And from the radiographic appearance of those teeth, that might give you a better indication of what might be happening beneath some of the restorations. There is no perfect answer, and it is very much depends on the patient in front of you. But if you go through those steps and you document everything you do, then you should be fine. Question from Mohammed Al-Ani. How to differentiate between infected and affected dentine clinically? As I mentioned, a tricky one at the moment. I would look at the texture of the tissue. I outlined this in my textbook, but what we say is the infected dentine is very soft and wet and sort of mushy texture when you put a probe into it. Sound dentine is very hard and scratchy. And in between, affected, you will get a little bit of scratching when you drag the probe across the dentine, but it will also cut up a small furrow as it digs through the tissues. This is why using hand instrumentation for excavation can be beneficial, because it allows you to feel these zones as you're actually cutting through the tooth structure. If you use a rosehead burr, often by the time you stop to check, you have actually cut too far. Some chemomechanical agents can also be very useful in trying to be more selective in caries removal, things like carousel gel, for example. Just looking at some other questions here. How do we, again, Irina, how do we decide to make an open or closed sandwich restoration? Again, a very good question. Ideally, if the clinical situation allows, I would always opt for the closed sandwich. I think the data from reviews from closed sandwiches show those restorations last better. However, clinically, that's not always feasible. Moisture control, whether the cavity is at gingival level or subgingival, can make life very difficult in that regard in trying to put a layer of resin composite over the glass ionomer or even the biodentine. So in some situations where the clinical situation is such that you feel that the operative procedure is too complex, then one must make a sort of judgment call. It goes back to my golden triangle, and it's a little bit like juggling three balls. And if you can manage the chemistry and appreciate the histology, you can work with the handling a little bit and make everything work a little bit better. I think I've got a little bit more time. Hassan El Shami question, which is better for direct pulp capping, calcium hydroxide versus MTA? So again, a really good question. Original MTA does take a long time to set, several hours, whereas there's modern MTAs that can snap set because they have some resin incorporated into them and you can actually light cure them. MTA probably has a slightly better biochemical response to the pulp cells, but really MTA is of the similar sort of family of materials to calcium hydroxide. Calcium hydroxide is cheap, probably easier to handle. So I would probably, for direct pulp capping, if you have MTA present, try to use that. If not, calcium hydroxide is perfectly reasonable. But if you can avoid the exposure in the first place, if at all possible, then that will be the best option. Let me see. Just trying to see. There's an interesting question from Mickey Singh asking how would this be incorporated into the NHS with its current UDA-based contract? Again, great question, and this is something we discuss more in the master's program. There isn't a simple answer to this, apart from the fact that actually the new contract in the UK is actually looking at prevention and risk assessment and actually patient responsibility. Now, as I hinted at, the business model currently may not be absolutely ideal, and that needs to be looked at in terms of how you use the funding from UDAs in your practice. But I can put another aspect to this, which is the medico-legal side. And I think we're getting very close to a time where if you are not offering MI dentistry and you are just solely offering traditional, in inverted commas, caries management, there will come a time in the not too distant future where you potentially could have medico-legal issues and you could be sued by people because you haven't actually offered MI. So we're at a turning point. We're at on the sort of tip of the iceberg here, where we need to change the way we deliver care, and as you rightly say, Mickey, the way the systems we work in also have to change, and we need to do this together. But I think that is something we should embrace rather than use as an excuse not to actually carry this out. Any other questions there? Let me just see. Actually, Minotti, is that Nicola Minotti, I think? Avoiding anesthesia can help to decide where to stop excavation. Absolutely. if you're excavating too deeply into vital tissue, the patient will obviously feel this. It's a slightly difficult one in terms of patients because you obviously don't want to cause discomfort. And if you're careful with your excavation, the caries affected dentine with spoon excavators can usually be removed without too much sort of negative stimulation. So I think, looking at the time, I think we're coming to the end of the presentation. Again, I'd like to thank all of you for listening in, and those looking at the recording. I hope this is of some use to you. Please do look out and look up my master's program from King's College London. It's distance learning for 3 years, and it's built for practitioners and therapists to be able to work in conjunction with their normal day-to-day clinical activity. It's a very exciting program, and I hope I've inspired one or two of you to at least look into it. Thank you once again, and hopefully see you soon.
Thank you very much, Dr. Banerjee, for sharing your lecture and your insightful information with us. We would also like to thank GC for making this online course possible, and thank you, our wonderful audience, for your interest and participation. The CE quiz is now available online on the course page, and completing it will allow you to earn your ADA CERP CE credits. The recording will be posted online within the next 48 hours. You will receive an email notification with a link to the recording. Further questions for Dr. Banerjee may be submitted directly on the website on the courses page under the Ask the Expert tab. So please go ahead and submit your questions, and Dr. Banerjee will be sure to get back to you as soon as possible. Please be sure to visit the Dental Tribune Study Club educational platform www.dtstudyclub.com and keep an eye out for our growing schedule of online courses. Thank you again to all. Take care and goodbye.